Good morning. Hi, this is Larian, and today we are doing a Facebook live session or a live session on multiple platforms, including YouTube. Um, and we have a lot of questions. So I'm gonna go ahead and start on the questions we have on primary hyperparathyroidism. Um, Sorry I was late. Had some car issues. Electric cars are sometimes not as reliable as we would like them to be. In any case, let's go ahead and begin. The first question is from Alicia Lee Garrett. Good morning. Thank you for doing this. My pleasure, Alicia. My most recent labs are below. Both my mom and my sister had parathyroid hyperplasia. I have parathyroid adenoma measuring 13 by 5 millimeters, which is large. Parathyroid hormone is 47, normal being 15 to 65. And another parathyroid hormone was 27 with a calcium of 9.9. Range of normal generally is 8.8 to 10.2. And vitamin D is normal at 44. 125 vitamin D is 102, which is on the high side. And urine calcium output is 400 milligram and still 315 while on a no calcium diet. I'm in Dallas, Texas, and cannot find a surgeon that's willing to take out the parathyroid adenoma. Okay, all right, Alicia, let me unwrap this a little bit. So, in that your mom and your sister have parathyroid hyperplasia, it makes it increasingly likely that you have hyperplasia and not just an adenoma. Now, adenomas may adenomas usually have a singular gland that's enlarged, right? But hyperplasia, all four are, except that they're not symmetrically enlarged, right? So they're not all the same size, and one of them may be significantly larger and may be visible on a scan, while the other ones may just not be big enough to show up on a scan. So that's one thing you may consider. You may have one parathyroid, hyperplastic parathyroid that's larger and visible on the scan and not necessarily just an adenoma. There is a chance that it's an adenoma that based on the genetics that you have, it predisposes you to getting parathyroid abnormality. And at the moment, you have an adenoma, but it is more likely that you have asymmetric hyperplasia. So that's one thing. Second, your calcium number at 9.9 is in the normal range, and your PTH at 27 and 47 are dynamic and in the normal range. Um, the only indicator that you have any disease is the fact that your 24-hour urine calcium is high and that your family members have hyperparathyroidism. So my question to you is, how is this disease impacting you? You know, the decision to proceed with surgery really has to do with how much is this disease impacting you. So is it impacting your kidney function? Are you getting kidney stones? Have you looked at your bone density? And is your bone density changed? And then when you look at the list of symptoms, are you suffering from these particular symptoms, right? Are any of these things that are predominantly taking over your life and affecting the quality of your life? Because if they are, then then certainly you should take action. Okay, and um, and be prepared for the fact that your surgeon in the operating room may take out that adenoma and your PTH may not fall enough, right? And then the surgeon may be forced to remove three of the four parathyroids and leave one of the last ones behind, right? In which case, you really actually need an expert surgeon. Now, it is hard to find a surgeon who's going to operate on you when your calcium and PTH are both in the normal range, right? You need to really show an indication that this disease is impacting you with normal calciumic numbers, meaning you either have to have lots of debilitating symptoms, progression of bone loss, or kidney stones or kidney malfunction. So I think that's why your surgeon in Texas is is hesitating. It's possible that if you show trending of your calcium over time, that your calcium is heading upwards, right? That if 15 years ago you had blood tests and your calciums were hovering in the, you know, mid to upper eights, and now they're hovering around the 9.9, which means your calcium has risen up and your normal calcium is in the eights, that your surgeon will buy it, right? And this may be, if you don't have osteoporosis symptoms or anything else, this may be the reason that you're preventing problems from developing, and you have such a strong family history that it's going to get there if you leave it alone. It's going to take either proof. Well, it's going to take proof essentially that this disease is either impacting you or that there is progression on it and that it will impact you in the future, and you want to stay ahead of the game. I think that's the only way to be able to succeed in convincing a surgeon to address this for you. And again, you have to be prepared that this may be hyperplasia and you need to remove more than one gland. Um, or if it's an adenoma now, be prepared for the fact that you may find in the future that you have hyperplasia and some of the other glands will need to be removed as well. That's the unfortunate thing that happens when people have a family history. Okay. Anyways, moving on to the next question. Please. Okay. Phyllis Gordon, thank you so much for providing this extraordinary opportunity. My pleasure, Phyllis. I was hyperpara and after surgery became hypoparathyroid. However, I'm now hyperpara again. So you must have had hyperplasia, or you may have recurrence. Anyways, while being hypo, I joined a clinical trial and for 5 years have received exogenous PTH replacement, meaning injections, PTH injections. Now I need to determine what the next steps are. What would you suggest as a decision making pathway to determine if the exogenous PTH, UV path, or recurrence of previously hyperactive parathyroid tissue transplanted into the forearm? Okay, so you had hyperplasia. They took all four of them out and put a portion of one into your forearm. Okay, is that causing extremely high PTH near the gland with normal range circulating PTH and systemic high calcium. If well, if the dosage of the exogenous PTH, the URV path that you're taking has not changed, but your PTH numbers are climbing, then it must be the one in your arm. Unless you have more parathyroids in the neck that were not removed. You have more than four, about 20% of people have more than four parathyroid glands. So it's possible that that may be the case. This is a scenario where venous sampling can help determine if the PTH is coming from your arm or if it's inherently in the neck. Okay, but we'll get to that. If I wean off the PTH replacement and the gland remains hyper, necessitating shaving or removal and does not prove to be reliable to regulate calcium within the normal range, thus becoming hypo again, initially I was hyper, three healthy glands removed, then the fourth one with an adenoma found in the chest and removed, and some of the tissue transplanted in the forearm. So meaning you had hyperplasia, and on top of it you had an adenoma, which does happen. That actually I find to be one of the reasons people have surgical failures. So here's a scenario. This person has hyperplasia and an adenoma on top. So it looks like that's what you had. Meaning all four of your glands were abnormal. In addition, one of the abnormal glands also had an adenoma on top of it. So If I do the surgery, if I wean off the PTH replacement and the gland remains hyper and necessitating shaving or removal and does not prove to be reliable to regulate calcium within the normal range, thus becoming hypo again, I will no longer have access to PTH replacement. It's, oh, because you're in a clinical trial. So if you go off the clinical trial, I got it. It's unclear what role the PTH replacement has played in the remaining paratissue becoming hyper again. None. Your PTH replacement is not what's causing the gland that was abnormal to become more abnormal. It just doesn't do that. In fact, it somewhat suppresses it, right? Well, not directly, but indirectly by keeping your calciums higher. So no role. It seems to me that your whatever number of remaining glands you have left behind, hopefully just one in your arm. Hopefully you have one in your neck and then you have one in your arm because it's impossible to shave down the parathyroid that was transplanted into your arm, right? Because you can't really see it. You know, what we do is generally we take the parathyroid, cut it in half, send half of it to the pathologist, and the other half we cut into small cubes, and then we go in the muscle. So if this is the muscle, we make a slit in the muscle, right? Open up that slit, and then stuff the little bits of parathyroid in there, and then close the slit, right? And so it's not a distinct area with blood, with a blood vessel going in and a blood vessel coming out, where you can go in and say, I'm gonna cut this end and leave the other parts, right? It's not like that because these each grow blood vessels on their own, each of these components. So when you go in there, you essentially have to go remove the whole thing. So when you have a transplanted parathyroid, you can't leave a portion of that behind. You essentially have to take the whole thing out, along with some of that muscle. It's not, it's not a very distinct thing where you can open the slit and get it out because it's all scarred down. So, anyways, I digress. Let me continue. I believe the hypergland and the resulting circulating normal range PTH is working in combination with the exogenous PTH, and one without the other may result in unfortunate events. So, for example, if a gland is removed, I may have extreme hypoparathyroid without the backup safety of the hypergland and no ability to get Yorvipath. However, if the hypergland remains and I'm no longer on Yorvipath, all right, the exogenous PTH that you're taking is not making the abnormal parathyroid in your arm act normal, right? That parathyroid is objective of that parathyroid is to get to a higher calcium level. It doesn't care how that calcium comes up. It doesn't care if it itself is producing PTH to get you up there, or if you're getting calcium PTH injections from elsewhere, as long as the calcium comes up to the number it wants. So your exogenous PTH is not is not changing the functionality of that parathyroid. That parathyroid is abnormal and is going to be abnormal. What I think you need to do is you need to come off the injections of the exogenous PTH and see how your numbers do, right? If you normalize and your PTH numbers are normal at this point and calcium is normal and you're feeling good, then I would say what's happened is that your parathyroid has grown large enough where you don't need support from the external parathyroid that you're injecting, okay? And which would be good, right? Which is the ideal thing you're hoping for when you have parathyroid autotransplantation, right? and then you're done. You don't need to do anything else. Now, if you come off the exogenous PTH and your remaining parathyroid in your arm continues to show elevations in PTH and your calcium continues to rise up, then you have a problem because that parathyroid is overworking. At that point, I would suggest doing an ultrasound of your neck to see if you see any extra parathyroids in the neck area, right? Doing this is the rare occasion where the selective venous sampling is helpful. You do the selective venous sampling because they can go in your neck and get samples of PTH, in your chest and get samples for PTH, and then in your arm. And then by doing that, they can say, oh, your PTH is only coming from your arm and nowhere else. The other numbers are low, and right? And then you know that you have only this parathyroid in your arm that you have to deal with, in which case you can go in there and remove it, knowing that you're going to have to go back to high calcium and vitamin D and potentially the exogenous PTH. Um, I don't know if you at that point can enroll in the clinical trial or actually get the exogenous PTH. I know that the company that was making the exogenous PTH was not very reliable. So so you are in a conundrum. But I think at this point in time, the main thing to do is stop the exogenous PTH, the injectables, see what your numbers do. Give yourself a few months. Um, I I don't know how that works with a clinical trial, right? If that cancels you out of the clinical trial, then you have to try to figure out how to address that. And you may have to tell them, or you may have to say ask for a break to see what the numbers are doing, or you may have to just do it without letting them know, right? But you got to figure this out. You got to figure out how to how is this affecting you, because this is your body and that's the priority, figuring this out, right? I would think that the clinical trial staff would understand the position and actually would want to know this information, right? That at some point your transplanted parathyroid took over and potentially you don't need it, or potentially the disease has returned, and whatever the case may be, right? But if your parathyroid in your arm is overactive and reacting, you can't continue to take the injections of parathyroid. It's not going to help you, right? You don't actually need that anymore, right? And you have to figure out an alternative path. This is tough stuff, Phyllis. I'm happy to talk to you again and try to go over the numbers with you. All right. But moving on. Good luck, my dear. Moving on. Kathy Namani. All right, Kathy. I have geared you mention in previous videos. I guess I've heard you mention in previous videos. You can be hyperparathyroidism and hypoparathyroidism. Can you explain this so I can show to my GB people? Please, I'm so ill. And well, no, you can't be hyper and hypo. You can be hyper and then go back into normal. By that I mean, when you look at the relationship between calcium and PTH. So remember, on the surface of every parathyroid gland, on, on the surface of every cell, there's these calcium sensing receptors, right? And let's do this again. And these receptors, there are hundreds of them on the surface, right? When enough calcium elements attach to that, it stops the release of PTH. And when there's not enough calciums, PTH. So when your calcium is up, your PTH is low. When your calcium is low, your PTH is up. So the relationship is inverse. Okay. Um, and so when you look on this graph, the relationship between calcium and PTH follows this inverse curve. And that inflection point there, we call the calcium set point, right? And that set point is genetically determined, right? Okay. So when you have when you have a set point of 9.5, when your calcium goes to 9.4, your PTH levels go up 50%. And if your calcium goes from 9.5 to 9.6, your PTH levels drop. Okay? So that can allow you to go back to this ideal set point that your body wants for your calcium. When you have hyperparathyroidism, what's happening is that your set point, which was originally 9.0 here, now for this one cell has changed to 11, right? So it's went from 9.0 to 11, okay? And so when your, let's say your set point is 11, this is a diseased parathyroid, right? Sometimes the calcium goes all the way, it follows the curve, goes into the normal range, right? And it may appear to you that you're back normal, but you're not normal. Your PTH is very high. And sometimes your calcium may shoot up and go all the way to a much higher number, in which case your PTH will be low, right? You're not normalizing. You're not going from hyper to hypo. You're just seeing the balance of calcium and PTH function on a different curve, which is an abnormal curve. Your body wants this, but the tumor is doing this to you and following this curve, right? All of this is abnormal, even if sometimes your calcium is in the normal range, or even if sometimes your PTH is in the normal range. It still is all abnormal. That's why you have to look at both numbers to figure it out. Okay. So no one listens in the UK. As I asked as well, can Sjogren's disease do this as only a few months back I've been diagnosed? Can this explain? Kathy, I think you were dictating this because it's not making sense. So you have Sjogren's disease, which is an autoimmune disease of your saliva glands. It has nothing to do with hyperparathyroidism. All right. Why would calcium and PTH be in the normal high, 2.58, and PTH of 5.9 in 2018 to 2023, and now last three blood tests, both calcium and PTH are in the normal range. The ultrasound says I have a 6 by 6 millimeter growth in the left thyroid. All of a sudden, it'd be a parathyroid in the thyroid, and I have symptoms back again like first time, on top of Epstein disease and celiac and Hashimoto's. Now I have Sjogren's and severe osteoporosis getting worse. I have so many autoimmune issues, fatty liver, pancreas. 2 months ago, had a 120 gram hypercellular adenoma removed. In December 2017 and 20, started feeling bad again. Kathy, I'm sorry, you're going all over the place. I can't follow. Listen, sweetheart. I think if you want me to help you, you need to kind of make a table, put the dates, when you had surgery, what your calcium, PTH, and vitamin D were before surgery, after surgery, and over time till today. Because I don't understand what's happening with you. You're all over the place and you have multiple diseases. And I'm not sure what you're saying. I don't know where the surgeries were, what the numbers were before and after surgery. If you know, I mean, if you had surgery 2 months ago and your numbers are normal now, then it would seem that you're okay. So if you're having symptoms, then we have to figure out if your numbers being normal is a one-time event now, and we have to track your numbers and trend them up to see if the numbers are erratic and sometimes normal and sometimes abnormal, and you're heading upward essentially, right? You're going to the disease, and so your curve is coming up gradually and getting there. Is that what's happening to you? It's hard to tell with the information you've provided. Yeah, please organize it. I really don't know what's going on here based on what you're put together. All right, and I know it's really hard when you have hyperparathyroidism and you feel like your mind is not um, working well. I know it's hard to organize. Have someone organize you. Email it to me, and I'm happy to help out. All right, my dear. Um, but I really can't make sense of this, unfortunately, and I really want to help you. Okay. All right, Esther Volants. Hello, Esther. Um, I read a lot of people after surgery have to take calcium supplements for life. Huh. People who have no parathyroid function will have to take calcium for life, calcium and prescription vitamin D. But people who've had a successful parathyroid surgery will need to increase their calcium intake until their bone deficiency, their calcium deficiency in their bone, or osteopenia, osteoporosis, has been resupplied, right? Once that's done, then normal daily calcium should be enough. I would say I prefer getting your minerals and vitamins and all these things through natural means, through your diet, rather than through supplements, right? And so what I do is I generally put my patients on uh, high doses of calcium for 3 weeks after surgery. Then I tell them after that, if you are the amount of calcium in your food, if you're eating a lot of green leafy vegetables, almonds, dairy products, almond milk, which all have high calciums, salmon, egg yolk, which have vitamin D, you're getting some sun on your skin, right? Um, then you may not need to take supplements. You can potentially just um, uh, do it through natural means. If you have osteoporosis, perhaps you need to take calcium supplements in addition to improving the calcium in your diet for a period of time until you resupply your bones. Okay? I think that's the best way I would advise you to do it. But no, if you have a one functioning parathyroid remaining behind, I don't see why you need to take calcium for the rest of your life. I thought that calcium supplements also come with certain risk, heart, intestine, kidneys, if you take them for a prolonged period. I mean, if you're deficient in calcium, right, then you're going to need either through diet or supplements. But if you're not deficient, if your bone loss is reversed and you have enough calcium in your diet, then really, why would you take supplements? Um, Sometimes I get the impression the surgery is done too quickly and you solve one problem and create another. Potentially. Potentially. By that I mean, again, if you have a parathyroid adenoma, right? And this adenoma is removed and you have three perfectly healthy normal parathyroids left behind, you're not going to have any problems, right? You're going to supply your bones, and once you've resupplied your bone, the calcium in your bones, then these glands will do their job and you'll have a normal life. If you have hyperplasia, right, and all four parathyroids are abnormal, and you remove three of them and leave a fourth one inside that has normal PTH functioning, then also you're in the same scenario, because all you need is half of a normal parathyroid gland to function normal, right? So in either one of these scenarios, these two patients were left with a functional parathyroid and they will live a normal life, right? On the other hand, if you have parathyroid surgery for hyperplasia, and all four are removed, right? And this last one is transplanted into your arm. 80% of the time that works, and 20% of the time it doesn't take when you transplant it in your arm, and you'll have no function, right? Um, and so it's in that scenario of the 20%, or if it's in a scenario where your surgeon is not checking PTHs and doesn't know if the parathyroid that was left behind intact in its original position with its blood vessel going in and coming out intact, without the PTH, you won't know what the functioning of that last gland is during surgery. And that can get you in trouble. So picking the right surgeon is really the key, Esther. Not so that you don't replace hyperparathyroidism with hypoparathyroidism. And I really feel that PTH testing is crucial, right? Especially if you do multi-gland exploration, bilateral exploration, and are trying to, you touch all the parathyroid glands. You don't know if you damage them beyond functionality or repair, right? Okay. And so sometimes I get the impression that the surgery is done too quickly and that you solve one problem and create another. Again, I explained why that could be. Yes, it's possible, but an expert surgeon who does PTH testing can prevent that. And that is my second question. When would you do watchful waiting instead of surgery? So that's a very good question. I would do watchful waiting for this scenario. Someone who clearly has hyperparathyroidism, let's say, but they have no symptoms. They've gone through the list of symptoms and they're fine. Their bone density is normal and not progressively getting worse. They have normal kidney function. You've scanned and they don't have any kidney stones, right? In that scenario, this disease is not really affecting you. You have choices. You can treat the disease so that you don't have to potentially deal with it in the future, or its progression or the consequences that it may cause, or you may monitor it, right? At that point, when this disease doesn't have an impact on you, you get to choose, right? It's your body. You get to choose if you want to do something about it or you just want to monitor it. And that's, as long as you keep monitoring it by getting serial scans and looking at your bone density every 2 years and so on and so forth, then you're fine, right? That's the scenario where I would. Now, if you have um, questionable numbers, if your scans are not showing any enlarged parathyroid, right? In that scenario, if your bone density is normal, you don't have kidney stones, and the kidney function is normal, and your symptoms are minimal, right, to none, you can also monitor, right? That also is the second scenario where you can monitor. I'm on a watchful waiting in Belgium, and you once confirmed me that that is okay if I do my yearly checkups. Yes, Esther, it is. If your practice, when will you do this and why? We explain. Thank you so much for sharing your knowledge. My pleasure, Esther. Good luck. I think you understand this disease based on your questions, that you're okay to proceed. I don't want you to work based on fear and not take care of it. I want you to not do surgery based on the fact that you're functioning well, your bones are not losing out, and the quality of your life is good. All right. So because the most important thing is the quality of our life, right? Life is complicated enough as it is to have an illness make you not function ideally. So just take that. All right. Good to hear from you again, Esther. Vivi Chi, Dr. Larian. I can't even say my name sometimes. You helpfully answered a question with 3D diagram about lithium last time. I have another. If someone has hyperparathyroidism thought to be secondary to lithium use for decades, is surgery the answer? Um, there are two options, either surgery or using Sensipar to bring the numbers down. Um, and the only thing that can be done about the symptoms is either surgery or taking Sensipars to bring to suppress your parathyroid gland to bring the PTH numbers down so your calcium comes down. Those are the only two options. And, lithium patients can be difficult. I just recently had a successful operation on a patient uh, and had hyperplasia, took out three and a portion of a fourth gland. The PTH numbers came down appropriately in the operating room, and she continued to have progression of symptoms. And we had to put her on Sensipar. And on Sensipar, she feels magnificent, right? She feels great. Whereas Sensipar before surgery wasn't quite as effective in making her feel better. So you may need a combination, right? Again, you need an expert surgeon to help you out. Someone who knows what they're doing and is going to follow you and not pass you along to the endocrinologist that may not be a partner in this in this disease with you or and with your surgeon. Okay, you need a doctor that's your partner essentially. All right, good luck, Vivi. Monty Stopia. Have you seen any association between folks that drink coffee all day long and hyperparathyroidism? I have not, fortunately. And there's lots of them here in the US. Can you speak with what the relationship is between hyperparathyroidism and reflux? My understanding is there's something about the esophageal sphincter getting relaxed. So yes, so our stomach is here, and there's a valve above the stomach that connects the tube, the esophagus that goes to the stomach. This valve is normally closed, right? And when you eat, it relaxes and then it closes again. So the food doesn't back up and acid doesn't come. Hyperparathyroidism causes muscle weakness. So this valve becomes weak and is open a little bit. So the normal acid in your stomach can leak up. Now, when your calcium numbers rise up, that aggravates your stomach and you produce more acid. So even more can rise up. So someone replied to Monty and said, Jennifer Ann, interesting. I just had to have mine stretched. Right. So over time, when this valve opens and you get acid exposure, it can form scars. And then the valve can scar down and needs to be stretched out. Right. So that can happen too. It's a later problem. Going on, Grant Seelig. Quick question or possible office visit. What have you seen post parathyroid removal with kidney function? Uh, GFR, which is the measurement of kidney function, and digestive issues with PEI. Thank you. Had undiagnosed disease for more than 5 years, and PTH was 1590. Whoa. So if your PTH was 1590, which is a massively high number, that either means that your kidney function was very much compromised. You're either close to dialysis or on dialysis, or you have parathyroid cancer, right? Which, if you're asking about kidney function, then most likely the close to dialysis or on dialysis is the answer. Now, the problem with kidney disease and hyperparathyroidism is that when you treat hyperparathyroidism, it doesn't reverse kidney damage. Damage that's done is done. It's not, the kidney is not an organ that regenerates. Unfortunately, it doesn't fix itself. Once it's damaged, then it's gonna stay damaged. I mean, sometimes you're borderline and you're about to go into dialysis and you fix the hyperparathyroidism and it just prevents you from flipping over. And over time, you get improved functionality, not 100% normal, but a little bit better, and you can just avoid dialysis. That can happen. But if you're already at the point of needing dialysis, you treat your hyperparathyroidism, that's not gonna allow your kidney to fully repair itself and flip back into normal, right? It's just not. The problem with hyperparathyroidism, as it relates to kidneys, is that it doesn't it doesn't it stops the progression of disease into worse. It doesn't fix the kidney, right? In terms of the kidney function. Now, in terms of kidney stones, it's the data shows that it takes about 10 years before you stop making as many stones, right? And during that 10-year period, the frequency of stone formations decreases, the frequency of emergency room visits decreases. And then at 10 years, I think the problem is mostly resolved, right? Because you may have multiple tiny little stones in your kidney that don't show up on a scan, and those may take up to 10 years to either pass or resolve. Good question. Tough problem, Grant. Lindsay Spell. Can you have false PTH results? My urologist, who my PCP referred me to for kidney stones, ordered PTH and calcium after she saw I had previous high calcium of 10.7. My PTH was 123 and my calcium was 9.7. So your calcium was high normal and your PTH was way above normal. Okay? That looks like hyperparathyroidism. A referral was made to the endocrinologist who then ordered PTH, entire calcium, and vitamin D. PTH was 60, so the PTH was on the upper end of, PTH was on the upper end of normal. Just going to try to stay consistent. And calcium was 10.4, which was above normal, right? So that's still hyperparathyroidism. Vitamin D was low at 20. I was told all were normal range, just take 1,000 units of vitamin D. That's not true, right? So in a normal parathyroid environment, right, when your calcium goes up, your PTH should go down, right? And this, this is what happens, right? This is the normal. For you, you originally had a calcium that was right at the upper side of normal, right? And your PTH was really, really high, right? And then your calcium went up and your PTH came in the upper to the upper side of normal. Your calcium was just right above the upper limit of normal or right at the border of it. This is not normal. This is not parathyroids do. This is what parathyroids do, right? So you still have hyperparathyroidism, except that now your PTH is back in the normal range, which is what we talked about when we looked at this scenario, right? When you get hyperparathyroidism and your tumor is now there, it's possible that for you, your graph is here, right? That your set point is 10 point, let's say 10.3, right? So when your calcium is at the 9.8 level, your PTH is really high, right? And when your calcium goes to 10.4, your PTH is, sorry, when your calcium is 10.4, your PTH is in the normal range, right? And that's probably what you have, but it looks to me that you still have hyperparathyroidism. And unfortunately, the vitamin D is not going to solve your problem. That's not your source. When people have vitamin D deficiency, vitamin D helps you absorb calcium in your intestines. So when you activate vitamin D here, right, goes to your intestines and increases the absorption of calcium from 20% to 80%, right? So if your vitamin D is low, that means you're not absorbing as much calcium from your food. If your vitamin D is low, then you are not going to get high calcium. You're going to get normal calcium or low calcium and elevated PTH, right? Because vitamin D also goes to the parathyroid glands and decreases PTH function, right? So in the original time where your calcium was high normal and your PTH was really high, that's not vitamin D deficiency, right? Right? And even worse now that your calcium is high at 10.4 and your PTH is not suppressed, that's definitely not vitamin D deficiency. That's hyperparathyroidism. And that's why when you take vitamin D, it didn't really correct anything, right? It normalized the numbers a little bit, but you're not normal, right? You still have hyperparathyroidism. Is it is there a possibility of lab error? Yes. biotin, which can be in many supplements and multivitamins, can falsely show a lower PTH number, right? So your second number may be falsely low for that. But I just think I don't see a lab error in the numbers you're sending me. I see I see an endocrinologist is not paying attention to what's going on. Okay. Um, what you need is further workup. So what I would do, if you were to come to me now, I would give you multiple prescriptions. I would ask you to make sure you're not taking any biotin, to do calcium, PTH, vitamin D 3 times, right? Fasting and at 8 o'clock in the morning, right? And they can be 1 week apart, 3 separate times, right? And you can be on your vitamin D supplementation for it. That's fine, right? And see what the relationship between calcium and PTH is. I would also check your 24-hour urine calcium, your at the same time as the blood test being done. I would check your creatinine and 24-hour urine creatinine. I would look at other reasons to have high calcium and high PTH, right? So the other reasons for high PTH are listed on this chart, right? I would try to correct those and see how that affects everything. And then I would look at the reasons for high calcium also and work that up. Let me find that for you. This is it. These are all the potential causes of high calcium. I would do a full extensive workup. I would put the issue to rest rather than send you home with just vitamin D replacement. Okay? Good luck, Lizzie. Don Dalders. I would be very grateful for some enlightenment. I will do my best, Don. I had successful surgery on September 2nd with one adenoma removed, others seen as normal, which tells me that they probably didn't do PTH testing during surgery. I felt fantastic after surgery as I'd been very ill prior with calcium at 3 and a terrific bone pain. All blood tests were fine during the surgery. Okay, so they did testing. And the next day. However, 6 weeks post-op, PTH had gone up to 7, but as my vitamin D was only 30, the surgeon felt that vitamin D 1000 a would correct this. All has gone fine until a few days ago when I started getting terrible spasms in one foot, upper arm, and one hand. Research told me was tetany each time taking 2 calcium tablets has helped. Should I still be taking vitamin D? Do I need to take calcium regularly? Do I need magnesium? Okay, you actually need blood test done to figure out where you're at now. Okay, you need to know if your calcium is too low, right? Because yes, spasms, muscle spasms, and cramping can be a consequence of low calcium, but usually tingling in both fingertips and around your lips happen first before you get the spasms. Sometimes you can't get spasms without it, right? So if you're getting spasms without the tingling, I think it warrants an investigation, right? You're telling me that taking calcium helps. That's a sign. That's a good sign that potentially you're don't have enough calcium in your system, and that may be related to vitamin D deficiency, right? But I think you just need labs, right, um, to see where you stand. Um, and what you need is calcium, PTH, vitamin D, and magnesium, right? And I would also check the 125 dihydroxy vitamin D as well, right? The regular vitamin D and the dihydroxy, because if your PTH is low now, then and your dihydroxy is low, then you may need the prescription strength vitamin D. So all of these will help. So calcium, intact PTH, 25 hydroxy vitamin D, 125 dihydroxy vitamin D, and magnesium levels are the things that I would suggest getting. Okay, my dear, best of luck. Sylvia Heath. I Hi, I had an ectopic carotid sheath adenoma. They did their best but could not remove the whole gland. It was not cancerous, but can it grow back or does it spread when cut open? It doesn't spread. I mean, it's possible that it'll spill, but it'll be in the local area. But if they didn't take out the whole thing and they cut it, then that's an abnormal gland that in time can grow and become abnormal. Now, based on how much abnormal glands that was left behind, it may take a lifetime and not get large enough to get you in trouble. Hopefully, the case. I am 3 months post-op waiting for new lab results. How to treat this as they cannot go back in there to operate a second time. I would have to see your scans and read the operative report to know why they're saying to you that they can't go back to operate. Okay. Um, First, second, your labs will tell us if you actually really need further treatment or not. You may not. They may have done enough. Sometimes when you touch these parathyroids, when you do surgery on them, then they scar down and then they die. So you may not need anything else. Okay, my dear. So I wouldn't be too worried without having the labs tell you anything. Okay. I've seen scenarios where parathyroids were incompletely removed and they never showed up again because they scarred down and died. And I've seen scenarios where, less often, scenarios where they did come back, right? More often where things went in a positive direction rather than a negative direction, okay? So hopefully that's the case for you. But you need to do the labs, and I would say if they left something behind, do the labs at least twice a day every 6 months, if not maybe every 4 months, if possible. All right. Erin Care Sorensen. Can I please send you my results and get your professional opinion? Yes. I have an MRI scan that clearly states possible parathyroid adenoma on the left thyroid lobe. Um, it's 3.5 by 5 millimeters. Every blood test that I have, the levels are high PTH, normal calcium, and low vitamin D. I've tried vitamin D supplements, which brought my vitamin D up extremely slightly, but still in the deficient zone, and my PTH came down into the 50s and 60s. Okay. Symptoms persisted, and vitamin D made me feel worse. Okay. Then Aaron NO says, send your results to a better surgeon. Ooh, Aaron, have I offended you? Reply, Cindy, Erin Anno, are you saying she should not send her results to Dr. Larian or a better one than she's now using? Oh, wow. Erin Anno, a better surgeon than she has now, of course. Her other posts stated that she lives in Vietnam. Not sure Dr. Larian is accessible for. Oh, I got it. All right. Well, so Erin Kerr Sorensen, the person posting, goes says, hi, Dr. Allen. Hope you're well. I finally got referred to a surgeon here in Vietnam on Monday. We spoke for nearly 2 hours. He basically told me he doesn't think my symptoms are caused by hyperparathyroidism, as my numbers are lower and my calcium is normal. He did not seem to be clued up on normal calcemic. Yes, I wasn't clued in on normal calcemic. A patient taught me normal calcemic hyperparathyroidism. That same patient who started me on the path of trying to treat hyperparathyroidism like I'm doing now, right? So it's possible that your doctor doesn't understand this disease. Gave me zero faith. My questions to all the endosurgeon GPs, my symptoms are not related to this disease. Why can't any of the people I've seen give me a reason or even try to investigate the reason why my PTH is constantly high? All right. So This is the chart, right? Take a picture of this chart. These are the reasons for having elevated PTH. So anybody who comes in with normal calcemic hyperparathyroidism, I have them go through this chart. I do a workup looking at all these things. I make sure they're not on any of these medications that could cause that. I make sure they don't have celiac disease, true gluten intolerance, which shows as an antibody, all right? Because that decreases absorption of calcium and vitamin D, kidney function abnormalities, renal leak, which is these are people who have kidney stones and massive amounts of calcium in their urine, right? I do a 24-hour urine calcium, right? Low calcium intake, right? Or malabsorption, right? I mean, 24-hour urine calcium will be low, serum calcium will be normal or low, right? Low magnesium can do it, right? So you need a very full workup to look at that, okay? That's the workup of all normal calcemic patients. They need to have that. Sometime, and I also look at the 125 dihydroxy vitamin D. If that's low, which can happen if the kidney's not functioning well, because this is made in the kidney, the vitamin D supplement you take is 25 OH vitamin D, which in the kidney gets transformed into that. So sometimes if you have a kidney that's not functioning ideally, you may have low that. And sometimes in the elderly, our intestines become resistant to the 24 this and don't absorb as much calcium because without this you don't absorb calcium. You absorb very little calcium, right? And so sometimes what I do is based on the full workup, I may put some of my patients on this, which is called rocalcitrol, and monitor their labs closely and see. And, you know, I'd say probably a few times a year, I find that a person has this issue, and by giving them rocalcitrol, I've corrected everything, and they don't need surgery, they don't need anything else, and they're fine, right? Okay, why my PTH is constantly high? This is potentially a reason. My vitamin D is constantly low, and now my iron is very low. 80% of the population of the world has low vitamin D levels, right? So there's controversy as to why that is, right? Um, for sure, not getting enough sun is part of it, but even here in sunny Southern California, that's what's going on. Even in tropical countries, there's vitamin D deficiencies happening. So maybe there's something else we're doing to ourselves as human to cause that. Iron deficiency is not related to hyperparathyroidism. Let's see. What else are you? The surgeon told me all the negative aspects of doing surgery and nothing positive. That surgeon is probably not doing as much surgery, right? Basically tried to get me not to do it. I feel so let down. My next option is looking for an experienced surgeon in Thailand. Good luck. All right. I mean, I think you need a workup, right? Get your primary doctor to work this up. Look at how, check this chart. All right. Um, Potentially even take this supplement, all right, and take this supplement, rocalcitrol. Um, and then um, and then if that doesn't work, go to Thailand, right? But do a full workup before going to Thailand, right? Because that may solve the problem. That may give you the answer. Okay, there's more thing. Aaron Eno is saying you just need a different surgeon. They don't take no for an answer. Keep pushing until you find the right more knowledgeable surgeon. I mean, I agree, but I think you really need a full workup first. Do this. Do this first, Aaron Kerr Sorensen. And then if that doesn't work, find another surgeon in another country. Okay? Good luck, my dear. This is very frustrating. Michaela Papakova Lastakaskas. Sorry for murdering your name. Hello, Dr. Larian. I have failed parathyroidectomy. Node removed instead of my adenoma. Any thoughts of it? Advice. I will have to have a second operation. Thank you. So, in Grant Selig says, did you go to an aborted endocrine surgeon? And Michaela says, I did. Um, Listen, I'd have to look at your numbers and the scans that you've had to see what happened to you and the pathology report. Um, Unfortunately, this does happen. Um, a lot of the parathyroid revision surgeries that I do are exactly for this reason. Um, and sometimes it's because they didn't see the adenoma, and sometimes it's because the person has hyperplasia and all the glands are just slightly enlarged and abnormal. So, I'd have to look at your whole chart and labs and numbers and everything to be able to help you more, Michaela. So either for the next uh, session that we have, create a table and put everything on there, or you can email me and we can set up a video consult and I can help you. But I need a lot more information to be able to guide you on this. All right, my dear. Moving on, Sam Richardson. Hello, I've been diagnosed with normal calcemic, intermittent hypercalcemic with hyperparathyroidism. Highest calcium 2.8 with parathyroid ranging 3.5 to 8.2. Okay, so 2.6 was the upper end of normal in calcium in the UK system, and I think 3.5 is the upper range of normal for PTH, and you're ranging from 3.5 to 8.2. And adenoma has been located on ultrasound, so the radiographer tells me, and I'm waiting for a sesame scan to confirm. UK, I'm confused about my diagnosis as I understand there's either normal calcemic or normal hormonal. Well, again, they're not telling you that you have normal calcemic or normal hormonal. They're saying that you have normal calcemic or some type hypercalcemic. And I think what's happening is this, that you're probably have a graph that came up from this to this, right? So most of the time, let me actually redo it. So most of the time, you're in the green box is normal calcium levels, right? So most of the time, you're in the green box and you have normal calcium hyperparathyroidism, and every once in a while, you're hyper. Your calcium is above the normal range. It's just that you're following the graph. That's all. That doesn't change anything, right? Um, if you're seeing the adenoma clearly on ultrasound, then I don't know why you're doing a sestamibi. If it's not so clear, then I would say instead of a sestamibi, do a 4D parathyroid CT scan, which is readily available in the UK system as well. Probably even cheaper than a sestamibi scan for the system. So that's what I would do. And better. Good luck, Sam. Helen Lunn, I'd like to understand more about normal hormonal hyperparathyroidism. I have mid-range PTH and persistently slightly raised out-of-range calcium. FHA ruled out with high calcium in urine. Vitamin D okay. I'm curious as to what's going on if PTH merely at inappropriate level, not raised, as in classic hyperparathyroidism. Okay, so let's look at that. Let me bring you a case of normal hormonal hyperparathyroidism. So this is that. the person's calcium is slightly above normal, right? A lot above normal here, and sometimes not so much above normal, right? And the PTHs are in the normal range. In this case, I would say they are not suppressed because the range of normal is 15 to 65, right? And at a calcium of 10.7, the PTH should be more towards the 15 than the 43. So that's already alarming, right? In this scenario, I have to rule out all the other known causes of hypercalcemia, right? Which is this chart, right? So I would have to do a full workup to do that, to get that. Uh, and once I've ruled out everything else, then I would go to treatment. So the idea with normal hormonal is that parathyroid hormone, PTH, goes and attaches to a receptors on the surface of cells, right? So if you have, let me see here. Okay, I'll do it here. So let's say this is, if you look at your bones, right? And if you zoom in and look at a bone cell, right? This is this cell, the bone cell, right? On the surface of the bone cell, there's a parathyroid hormone receptor, right? And the parathyroid hormone receptor, let's say, has this shape, right? Parathyroid hormone may look like this and fit in exactly into there, right? So this receptor, then once the blue thing attaches, right, it starts a whole bunch of messaging system inside the cells that does what it does to the bone, okay? Um, or the kidneys or any of the other organs that have the parathyroid hormone receptor, right? Now, you don't have only one of these red things, you have multiple, and I'll draw them as triangles, right? So actually, I'll just do this, right? So you have hundreds of them, let's say, on the surface of every cell, right? If these have a shape that fits in the blue one even better, right? Which means that once the blue ones, there are a whole bunch of these blue things are free floating around, right? If the receptor that you have fits this in much better and holds it in, right? Then when this is attached and sitting there, you're gonna have more of a reaction, right? Which means that your receptor is more sensitive. The shape of your receptor is more sensitive, right? And so the people who have normal hormonal have very sensitive receptors, right? And don't need as much PTH to get this reaction inside because they're sensitive and they have a receptor that holds on to that hormone longer and reacts to it more vigorously. Okay, so you don't need as many PTHs to get hyperparathyroidism. That's the whole idea of normal hormonal hyperparathyroidism, right? And so, okay, when you look at someone, so when you have someone who's normal hormonal, let me see if I have a better graph to show you. Okay, so this is the normal graph for someone who doesn't have a sensitive receptor, right? The graph of calcium versus PTH is like this. For someone who is sensitive, the graph is like this. they don't need as much PTH variation up or down to to change the calcium numbers. A lot less PTH can do it, right? And when this person becomes hyperparathyroid, the graph that they have is like this, right? The graph for someone who's normal would be much larger, right? So you have a sensitive system, you don't have as wide a range, and when you get hyper normal hormonal hyperparathyroid, even though you're abnormal, your range is still not a lot. So your PTHs may not go above 65. So the upper limit of normal is 65. Your PTHs may not go up there. You may stay remain. That's what normal hormonal is, right? It's the same disease, and the treatment is the same. The surgery is the same. All right, Helen, good question. Aaron Eno. Aaron Eno, you have had multiple appearances today. Okay, here we go. If you've had this disease for a very long time and have severe osteoporosis, muscle weakness, muscle loss, and can your labs eventually start showing lower calcium numbers due to less calcium being available to pull from your bones? Um, yes, but it would have to be exceedingly late in the disease, right? Like, I mean, you've had multiple fractures at this point. You just don't have any calcium to give, right? Because parathyroid tumor doesn't care what's happening to your bones. It just wants the calcium level in your bloodstream to be high. So if you have any bones, it'll try to it'll produce PTH, which will leach out calcium out of that. So you have to have basically very little, no bone left for that to happen. Um, my latest few labs have been lower in calcium. If your labs are showing that your calcium is now lower, right? I would say that you're just in a different part of that curve, right? So you're sorry. So you're operating on a, if your curve is like this and your numbers are now in the normal range, you're just operating on a different part of the curve more likely rather than having no calcium in your bones left. So I can better answer you if you give me both calcium and PTH numbers, right? Without knowing both, it's hard for me to know what's going on with you. And if you're just tracking on the nerve, on the curve, there have been incident reports of someone having a parathyroid adenoma, which was cystic, and then the cyst involuted, and then the immune system reacted to it and ate away the parathyroid, right? That they disappeared. Is it possible that that has happened? It's possible. It's exceedingly unfortunately rare, right? But more likely, you're just inching along in a different portion of the curve than anything else. I see that. Okay. Oh, okay. Erin just reposted her question. Okay. So, Erin, I need more information to be able to appropriately answer it. If you have the numbers, you can put it up on the chat right now and I'll look at it. Okay. Chris Powers, do you treat hyperplasia? Absolutely. Um, you have to treat hyperplasia. If this disease is impacting you and you have hyperplasia, it has to be treated. And the treatment is just like I showed you previously. This is the steps of treatment. Right? The treatment is to get you to this. And so, you know, just to kind of break it down, I don't do it this way where I check PTH between each one, but I do remove the three largest and cut down the last one to the size of almost the normal and check PTHs. And based on the PTH, decide if I need to remove more or we're good. Okay. So here we go. These are the steps. First, the incision is the same as anything else. I separate the skin to see the muscle layer. These are the muscles you can see on each side. Then I retract to show the thyroid. The thyroid gland is here over the breathing tube. And here you can see the thyroid. Right? Then I go find the parathyroids. I check a PTH right before touching any of the parathyroids. Here are the two parathyroids on this side. Then I go to the opposite side, look at the parathyroids. These are the two. And lo and behold, this parathyroid is the smallest, right? In which case, I biopsy that smaller parathyroid to confirm that that's a parathyroid, remove the bigger upper one, go back, remove the other two, right? And then check PTHs again. And if the PTHs drop appropriately and stay in a steady level in the lower side of normal, then I know I'm done and successful. Sorry, I had a call coming in. Put one suture in the muscle, two layers of sutures under the surface, right? Bring the incision together, and then put a tape up and done. Draw what I did during surgery, and then put my patients on citrical, magnesium. Citrical has calcium and vitamin D and magnesium, right? I oftentimes give patients arnica and bromelain to decrease swelling and bruising. Anyways, that's what I would do. That's how I would treat hyperplasia. And because I do the PTH testing during the surgery, I know that the remaining parathyroid is functioning appropriately for you. So if it's not, if the PTH is too low, then I would transplant a little bit more parathyroid in the muscle of your neck. Arlene Cochran. Hi, Dr. Larian. 3 weeks ago, I had 3.5 glands removed. My PTH didn't quite decrease by 50% during surgery. I've not experienced any symptoms of hypocalcemia and only took supplements for a week. Is it possible I have a fifth gland that's working to keep things stable as my labs today are good? Either that or that 2/3 of the gland that they left behind has scarred down a little bit or is in shock, right? Hopefully it's scarred down and is functioning less and you're going to be good for a lifetime, or it's still in shock and your numbers are okay, because 3 weeks is a little bit too early to judge, okay? It's also possible you have a fifth gland that was in close proximity, so when they were doing the surgery, they touched it and put it in shock, right? Or potentially cause damage to the blood vessel next feeding it and it scarred down and now it's better. Anything is possible. It's just too early to tell at 3 weeks what's going on. I would do the labs in another month, in 3 months, and 6 months, and look at the trend to figure out if things are good and you're okay and you're staying okay, and then annually thereafter, or no, the numbers are creeping up and you may need more to do here. A little bit too early, Arlene, but we'll keep our fingers crossed and hope that you don't have to visit any of us surgeon types again. Maggie MC, hi there. Dr. Larian, thank you for taking my question. I'm a 63-year-old living in France. I've been symptomatic 10 plus years with hyperparathyroidism. I've gone from being completely dismissed to questionable secondary hyperparathyroidism, then reluctantly to normal calcium hyperparathyroidism. I had a gastric bypass in 2009. I know this can muddy the waters, but knees replaced early 2022. The surgeon was surprised by rapid deterioration of both knees in a short space of time. I have osteoporosis with a T-score of negative 3.2, normal kidney function, no scans. My doctor wanted me to start 100,000 units of vitamin D every 15 days for 3 months. Oof. Okay. Also to start bisphosphonates and review in 6 months. I feel that is not a good way to go. looking at my results for the last 2 years, what do you think? Let me look at your results. Thank you for making a chart. Calcium is the normal range is 84 to 102. Your numbers were early 2023, 97, 94, 100 by mid 2023, late 2023, 95, 2024, 97, 97. So high 90s, low 100. Your PTH upper range of normal is 68, as in 2023, 88, 76 above normal. Okay, so you have normal calcemic hyperparathyroidism, because your vitamin Ds were normal at some point and your calcium was upper side of normal and your PTHs were elevated. So you have normal calcemic hyperparathyroidism, right? Again, I would go to that chart and rule out all the other causes before embarking on surgery, right? I'm going to bring your chart again. This is probably one of the most valuable things I have to show people on these sessions, so that you can use this to go do a full workup. Okay, and then you have more labs and another chart. Calciums are the same. The PTHs are, again, yes, they're either slightly elevated or in the upper range. But again, if you look at your calcium are on the upper side of normal and right at the border of being abnormal, and your PTHs are now ranging here. This is not normal, right? A normal thing is this, right? Even if your set point is, let's say, 98, then you should have this happening, right? PTH has changed widely with minor calcium changes, as you saw, right? So if your set point, your normal set point is, again, let's see, your range is 88 to 102. Yeah, which is, we have 8.8 to 10.2 years, have 88 to 102, right? Okay, all the same. And let's say your normal graph set point is at 100, right there, right? Then you should have a range. When your calcium goes from 100 to 102, your PTH should precipitously drop, right? By more than 30%. And if your calcium goes from 100 to 98, your PTH should increase, right? And you're not doing that. You're not having this wide range. Your ranges and your PTHs are much more narrow. So you're not having a dynamic relationship between your calcium and PTH. So I firmly believe you have normal calcemic hyperparathyroidism, right? Do the workup of elevated PTH. And if that proves to be negative, right, then you're going to need surgery, my dear. Good luck. Marianne Wasp. You know, I've been to the hospitals in France, and I've seen how they manage their healthcare system. France has a pretty good healthcare system, right? There's no frills, there's no pretty, you know, hospitals like the ones in the US that waste all sorts of money instead of taking care of the patients. Your system takes care of patients very well. I had a friend who was getting dialysis in France, so I was going to the hospital on a regular basis, and I see how they function. So you may have to look a little bit more and find a better someone who listens to you more. Okay. Marianne Waspe. Hi, Dr. Larian. Thank you for your help. I'm in Australia. In 2019, I had 3.25 glands removed for hyperplasia. I have a titanium clip on the remaining 3/4. My labs were only normal for 6 months, and I'm back where I was in high PTH. Normal calcium and vitamin D, PTH always 12.7 or more. Range is 1.5 to 7.6. Thank you for including that. And it says secondary to low calcium. All right. To Marianne, what I would say is do a 24-hour urine calcium. All right. Because if your 24-hour urine calcium shows that your calcium output in your urine is high, then the calcium you have is higher than what your body wants. All right. And taking calcium isn't going to solve the problem. So if your 24-hour calcium is normal or elevated, then taking calcium supplements isn't going to fix the problem. All right. If your 24-hour calcium is low, then that means you don't have enough calcium in your bloodstream and your PTH is high. That's how I would say. Okay. I was put on Prolia for osteoporosis, had kidney stones 10 years ago. This was all prior to gastric bypass. I don't know what to do. Thank you so much. 24 urine calcium, dear. Right? Do the calcium, PTH, vitamin D, 25 hydroxy vitamin D, 125 dihydroxy vitamin D, magnesium level. That's right. Uh, take this chart to your primary doctor and have them do a full workup. Right? Look at that. And then 24-hour urine calcium, which is part of this workup. And then if your 24-hour urine calcium is low, then it's your low calcium intake, right? And you take calcium supplements. If your gastric bypass prevents you from absorbing it, then there's sublingual calcium that you can take, right? There's some available online, right? And sublingual vitamin D, okay? Right? Now, if if none of these pans out and you have persistent hyperparathyroidism, then I would do what Alicia Lee Garrett suggests, which is to do a 4D CT scan to see if you can find the fifth gland. Or it's potentially your fourth gland that three-quarters of it remains that's now overworking and may need to be reduced. All right. Alicia Lee Garrett says, my mom had two surgery, had 3.5 glands removed, then her PTH was high again. She had a fifth gland. They found on a CT scan, 4D CT, and she had to have that removed also. And that happens too. All of these are possible. You just need a more of a workout. Nicole, Nicole Laura Jones. Hello, thank you for this Q&A. I previously had surgery in 2012 when I was 50 and removed one adenoma. After a few years of levels being good, my PT started to increase and has been high since 2018 with symptoms. The scans and ultrasound have been inconclusive. I went to my endocrinologist who was part of the 2012 surgery, and he says because my calcium has not been high, I do not have hyperparathyroidism again. I mean, what do I say to that? No. Again, you need to have your endocrinologist look at this graph and work it up for you, right? And if this all proves not to be the case, then you have normal calcium hyperparathyroidism. You know, the deal with hyperplasia is this. First, you can't cure someone who has hyperplasia, right? Because all the glands are abnormal. That's hyperplasia, right? So this is someone who had four gland hyperplasia. In hyperplasia, what you have multiple adenomas and nodules in each gland, right? You can see it, okay? And then you have some areas of normal parathyroid in there, right? This is normal, right? Anyways, each of these areas of hyperplasia may have a different setting for calcium, right? This could be 9.8, could be 10.5, this could be 11, this could be 12, This could be 10.0, right? And depending on which one is big enough to dominate, right? So if this one is the biggest of the nodules, right? And this one is set point 9.5, and your natural calcium number set point is, let's say, 8.8, right? Right? Then you're going to have a calcium of 9.5 mostly. Let's say this one in another gland in the right inferior is set for 9.7, right? You're going to hover between 9.5 and 9.7 because these are dominating, right? The 12 is too small to dominate, okay? And that's what you get when you have hyperplasia. So they took out these three and a third or a quarter of this one. You still have abnormal parathyroids in there, right? And as they continue to grow, you may develop a new nodule in here, right? That is growing and dominating, or one of your old nodules may grow and dominate and get you to the number that that was set for. And if that number is, let's say previously, these were set for, let me erase everything. Okay, let's say originally these were set for 10.5 and 10.7. Your normal is 8.8, right? So you have calciums that are ranging somewhere between these two numbers, right? You go into surgery and then you have this one whose nodule is a calcium that's set for 9.7, right? You do surgery, you remove these three, you take off this much from this one, you've left this in place, right? Your calcium goes towards the 8.8 and starts to slowly rise up towards the 9.7 as this one gets bigger and bigger and bigger, right? By looking at a parathyroid, we can't tell what the set point of the calcium for that nodule in that parathyroid is. We just don't know, right? We're going for removing the smallest parathyroid because it has the slowest growth rate, right? The bigger nodules are the ones that dominate because they produce the most amount of PTH, right? So that's why we go for the smallest and we try to shrink it in size, right? It's all a guesstimation, right? If we see a nodularity by looking at it or feeling that parathyroid, okay, we'll take out the side of the nodularity. But if the blood vessels are coming into the gland from this side, I'm coming out from that side, I can't take this side out even if it's nodular. I have to remove the opposite pull from the blood vessel because if I don't, then this parathyroid dies, right? In any case, and reimplantation has a 20% failure rate, right? So you're kind of stuck. In any case, excuse me, it's it's probable that this is the scenario that you have, right? That you had higher number of nodules in your parathyroid that were removed, and now you're stuck with this thing, and this one is dominating it, and it's higher than the 8.8 that your body wants. So you're normal calcemic hyperparathyroid. Okay. Okay, hold on. Nicole goes on to say more. She said your endocrinologist said some people just have high PTH. If your PTH is normalized and now going up, then you did the surgery in 2012, and your PTH started getting high in 2018. That's an elevation. If your PTH was always high and you had no symptoms and no problems, then you may have less sensitive receptors to PTH, and your range of normal, instead of being 15 to 65, maybe 50 to 100, right? But your PTH is rising, so this doesn't make sense, right? I also just did a 24-hour counseling and it was high in the high range, right? So your normal calcium in your bloodstream, which the lab says normal, is not normal for you because your kidney recognizes that, right? The kidney has the same calcium sensing receptor, right? Which is not faulty as it is in your hyperplastic parathyroid. And your kidney recognizes your calcium number to be too high and is trying to excrete it out. Why should I do that? I feel as though I've exhausted all my options. 24-hour urine calcium was 339. Normally is less than 300. Vitamin D 45, which is in good range with 5,000 units daily. Calcium is 9.5. Calcium is 9.6 and PTH is 90. So calcium is in the normal range, mid-range of normal. PTH is elevated. Your vitamin D is normal. Again, do the full workup. Take that chart to your primary doctor or endocrinologist. Have them do that, right? And then and the DEXA scan shows osteopenia and osteoporosis, right? So your disease is progressing. You gotta interject, right? I find that most people who fail or have a recurrence, it's because they had hyperplasia, right? And the hyperplasia just um, and they had an adenoma growing on top of the hyperplasia, right? So this is most common reason for my failure. The failures in my head. I go in to have a big adenoma. We see it on the scan. We do the surgery. I take this adenoma out. The hyperplastic cells, parathyroids, are just minimally overfunctioning, not enough to be hugely problematic, right? I take this out. The PTH in the operating room drops. The patient feels better because the amount of PTH produced by this minimal hyperplastic parathyroids is not a lot, and it takes years and years for them to grow and produce more PTH, right? And that's probably the scenario for you. It's also possible you have a second adenoma developing, which roughly 3 to 10% of people who have one adenoma can develop another one. You need a good team, Nicole. Um, but but keep at it. Don't relent. All right. Good luck, and I'm here to help you out if you need it. Jennifer Ann. Hi, Dr. Larian. I had three gland hyperplasia surgery 2 years ago. My question this round is, every scan and x-ray that I have on any part of my blood shows I have calcium deposits everywhere from having had the disease for 10 plus years, including in my heart. What do people like me do about this in the long run? Obviously, surgery stops it, but does this stuff ever disappear or go away? Is there something I can do at this point? As always, I appreciate your dedication to this disease. Those who have suffered it, effect is vitamin K2 helpful. Vitamin K2 helps your bones, so the bone loss, but it doesn't take away calcium deposits in your tissue. The only thing that I know of that can help, potentially help, and there's no research showing that it helps with calcium deposit, is doing stuff that promotes stem cell regeneration, right? Which is 5 day water fast twice a year. That's a known fact. That promotes stem cell regeneration, right? Cold plunges, um, saunas, uh, 3 times a week, cold plunge 3 times a week, saunas 3 times a week, exercise, regular exercise, eating well, minimizing sugar intake, minimizing um, red meat intake. And I'm not saying to take it away, but sugar is not natural to our body, processed sugar. So very little amounts of that. And red meat, well, we weren't having red meat a lot, right? Evolutionarily speaking. So minimal amounts. I have one red meat dish a week, right? Anyways, that's the only way I know that you have the potential of harnessing your body's ability to regenerate itself, to regenerate your organs. At least at this point, that's what we know. Good luck, Jennifer. Maria Stajkovic. Sorry about mispronouncing your name. Hi, Dr. Larian. Greetings from Croatia. I'm 38 years old. The table shows my lab results for the last 2 years before and after parathyroidectomy. Ultrasound was positive, scintigraphy negative, FNA results showed parathyroid cells. Lower left gland removes, minimally invasive. IOPTH was 337, it spiked and was partially torn. Normal cells after the operation because of elevated values. June of 2023, another scan was performed. Weak accumulation was in the upper left lobe. Additional SPECT CT was performed, which was negative. There was no bone fracture or kidney stones in the history. Kidney function is normal. I have a few small nodules and cysts in the thyroid, but hormone levels are normal. Let me look at your numbers. So October of 2022, PTH is 127, calcium is elevated at 2.6, vitamin D is 32, not bad. January, okay, surgery was January 2023. February, in January, after 3 days after surgery, your calcium went down to 2.43 in the normal range, and PTH was slightly elevated at 75. By April, your calcium was at 2.57, PTH was 102, same as before surgery, and your numbers have continued to show elevations, right? After you took 1200 IUs of vitamin D every day for 6 weeks, your vitamin D came up from 47 to 55. Your calcium was high, your PTH was still high, but lower than before. From 100, it went to 83. Increase the vitamin D, and then once your vitamin D reached 116, your calcium was normal, and your PTH has continued to stay elevated. Right? You have persistent hyperparathyroidism. All right. Okay, let's see. In November 2024, PET CT choline PET was performed. They found metabolically active upper left gland, 1.1 centimeter near posterior edge of the trachea. Now my question, are my lab results suspicious? Yeah, you have hyperparathyroidism, dear. You do, Maria. You have hyperparathyroidism. You may have another adenoma, or you may have hyperplasia. You need your surgeon to say this to you. That the surgeon may go in and find that that's a second adenoma, and they remove it and everything's fine, and PTH drops. You say intraoperative PTH was 337, right? It has to stop from 337 to the normal range. It has to go, 2030, right? If that doesn't happen, the surgery is not done. You have hyperplasia, and they need to look at the other two glands and remove two of the remaining three and keep checking PTHs, right? My criteria for reoperation is now you have persistent hyperparathyroidism. You had one surgery already. You need another one. Proceed. Um, just go with a surgeon that has massive amounts of experience. All right. That's for the questions that came in during. Before. Let's see if I have questions here that I can answer. Polymorphy. PTH is 80. Phosphate is 0.5. Waiting for vitamin result. But it was 11. Does elevated PTH always mean growth? No, it doesn't. And again, elevated PTH requires the workup of these conditions, right? This is what needs to be worked up. Okay. Oh, Tony says my volume is very weak. Sorry, I just saw it. Polymorphism, also a lot of weakness and tetany at times. Okay. Patsy Johnson skeleton. My PCV gave me calcitrol. My vitamin D is 30. Still had surgery in May. 3 tumors removed. Calcium PTH number are good now. Great. Lucy Areola Torayo. I had one gland removed 15 years ago. Recently had scans which showed 3 remaining glands to be enlarged and need to be removed. One surgeon suggested transplanting a piece in arm. What tests would you suggest before surgery? Well, no. I mean, if they removed one gland before, I wouldn't do venous sampling. Venous sampling is for people who've had transplantation of the autotransplantation of the parathyroid in the arms. That's the only time that I really found it helpful for me. For you, if you have scans that show the remaining 3 glands to be enlarged, you have what most people who have failures do, which is you had hyperplasia. You didn't have an adenoma to begin with, right? You may have had an adenoma on top of hyperplasia, and now the surgeon needs to go in and remove at least 2, maybe 2 1/3, 2 1/4, 2 1/2, based on PTH testing. So you need the surgery to be done with intraoperative PTH testing. Taking high doses of calcium will not cause gut damage, right? It can cause constipation, it can cause upset stomach and things like that, but it won't damage your guts, right? In which case you can switch to the sublingual calcium. Penny Daw. I had one gland removed successfully in 2019. I've had blood tests annually since then, all all clear. My GP is suggesting that I no longer need an annual PTH blood draw, vitamin D, and calcium test. Do you agree? No. There's a 3 to 10% lifetime chance of getting another adenoma. I would continue to check it with your annual exam. My calcium was 2.71. Jonah H. My calcium was 2.71 above normal. PTH is 25, lower side of normal. Cinecalcid lowered to 2.33. FFH was excluded. MRIs are clear. MRIs are not good scans for hyperparathyroidism. A choline PET CT is planned, but my doctor rules out primary hyperparathyroidism due to low PTH. Well, no, you could have normal hormonal hyperparathyroidism, right? Could this be wrong since the other causes should suppress PTH? I wouldn't respond to cinecalcid. Correct. No, you may have normal hormonal hyperparathyroidism. Normal hormonal hyperparathyroid patients also respond to cinecalcid, right? But for for that, you have to rule out all the other causes of high calcium, right? Which is this. So you have to look at this. Julie Devereux. I have been reading that hyperparathyroidism can leave calcium deposits in various parts of the people's bodies. Is there a link between hyperparathyroidism and higher levels in heart calcium scores? There's no direct link, but if you already see the calcium scores that you get on the CT scan of the heart is calcium that's deposited in cholesterol deposits, right? So if you don't have cholesterol wrapped around inside the thing, inside your blood vessel, there's calcium can't embed in it, right? So it's the cholesterol that's the main source, right? So if you have hyperparathyroidism but no cholesterol issues, you're not going to get calcium scores that are high, right? If you if you have cholesterol issues, then having hypercalcemia, you may get more calcium deposits in it. Pedro, I had one parathyroid adenoma removed in November, and I have been taking vitamin D supplements since March of 2024. Should I continue? The latest blood test showed acceptable vitamin D levels in October. I would say stop the supplements and see what your vitamin D does in the next 3 months, right? And if it stays normal, then you're good. You have enough in your diet and sun exposure. Very Sridhar Pandit says, PHPT, which test do you prefer? Initially, calcium, PTH, vitamin D, fasting, and at 8 o'clock in the morning, making sure you're not taking any biotin supplements. And I prefer the ultrasound first. If that doesn't work, a 4D parathyroid CT scan rather than the SSTMV. Hasna NK. Hello, doctor. I have hyperparathyroid with normal calcemic levels in my blood, but low calciuria in my 24-hour urine test. I've already had 2 thyroid surgeries to remove 2 lobes, and then my PTH is high at 100. I did a vitamin D test, which is normal also. I don't know what steps. Okay, so if your calcium is normal, calcium is normal, and your PTH is elevated, so you have normal calcemic, potentially hyperparathyroidism, and you do a 24-hour urine calcium, it's low, you either have low calcium intake or you have malabsorption, right? And that's what you need to figure out, and that's what you need to overcome. You may need to take calcium and vitamin D sublingual, right? If your guts aren't absorbing it. Lori Cunnert. After several imaging scans, ultrasound SPECT CT and CT with contrast, I've been told probably I have small adenoma on one gland, but also potentially hyperplasia. How is that handled surgically? Well, I would remove the adenoma first, check your rapid intraoperative PTH. If it doesn't drop appropriately, then look at the remaining 3 glands and see if there's a second adenoma potentially, or you have hyperplasia, in which case I would remove, excuse me, 2 of the remaining 3 glands. Excuse me again. Why do I feel uncomfortable around my neck when I wear a pullover right where my adenoma is? You don't feel the adenoma. There's no nerve branches going to the parathyroids for you to sense it, right? And they're too small to feel. So there must be something else going on. It could be that hyperparathyroidism is causing sensitivity of the nerves in your neck. It could be that you may have Hashimoto's thyroiditis, which is autoimmune disease of the thyroid, which will make your neck sensitive. Or you could have acid reflux from hyperparathyroidism causing inflammation in the neck area. Unfortunately, I have to end this session now. I have patients now in the office waiting for me. I hope I was helpful. Wish you guys the best. The winds have quieted down here in Los Angeles, so the fires are being contained by the heroes, the firefighters, and hopefully we'll get a handle on this situation, a better handle.